Okay, so I think we'll get started. I would like to welcome our audience from across the globe to today's Kosaka Best of Meeting Abstract presentations. Today's session is made possible by the insightful vision of Dr. Futami Kosaka, founder of the Japan Society for Clinical Anesthesia. Dating back to 1990, Dr. Kosaka started a collaborative relationship with the IARS and developed the foundation for today's award sessions. The session has been named in his honor. We are here with the top 8 IARS abstract authors presenting in the clinical, research, basic science, and scholars abstract categories. Their submissions have been chosen by our reviewers to be highlighted during this Kosaka Best of Meeting Abstract session. We also have 2 top scoring late-breaking abstracts that will be presented that are not considered for the Kosaka Award prizes. The top 3 finalists in each abstract category will present their abstract orally and compete for the top award in session and be eligible for a $500 prize apiece. Before opening the session, I would like to ask our audience members to type questions into the chat box in real time, as each presenter will only have 3 minutes to reply. On behalf of Dr. Prakash and the entire IARS board, we welcome you to this exciting 2022 session. Thank you, and I'll turn it over to our first presenter, Dr. McKinstry-Wu.
Hi, thanks for having me. I'm Andrew McKinstry-Wu, and today I'd like to share with you some of the discoveries my lab has made in identifying the proximate neural targets for alpha-2 adrenergic sedation and hypnosis. And before I go any further, I'm an assistant professor at Penn, and I have no disclosures to make. As alpha-2 agonists produce sedation and hypnosis through the alpha-2A receptor subtype, we created a mouse line with FLOX-ADRER2A, which is the gene encoding for the alpha-2A receptor. And this line allows for cell-specific knockouts of the alpha-2A receptor through expression of Cre recombinase in cell types where we want to delete alpha-2A. By crossing our lines with other lines expressing Cre under the control of promoters specific to adrenergic, subcortical glutamatergic, GABAergic, or pan-neuronally expressed, we created mice lacking alpha-2A receptors only in those neuronal subtypes in order to determine which of those subtypes alpha-2 agonists act directly on to produce their sedative hypnotic effects. As a behavioral measure of hypnosis, we looked at loss of writing in response to intraperitoneal dexmedetomidine. We found that elimination of the alpha-2A receptor in either adrenergic or subcortical glutamatergic neurons completely ablated writing reflex in response to dexmedetomidine. And that was similar to what was seen with the pan-neuronal knockouts. And in contrast, the GABAergic alpha-2A knockouts were indistinguishable from our FLOX controls. And we looked at 2 behavioral measurements of sedation, a forced movement, which we see on the left, and a spontaneous movement task, which is the graph on the right. And the forced movement task, the mice balanced in a rod that rotated for 60 seconds, and we tested them on that 15 minutes after drug administration. We measured the average time they stayed on the rod over 3 trials. And in this test, the adrenergic alpha-2A knockouts displayed some resistance to the sedative effects of dexmedetomidine and were able to stay on the rod longer than the FLOX controls. While the subcortical glutamatergic alpha-2A knockouts were profoundly resistant to sedation and behaved similarly to the pan-neuronal knockouts with little, if any effect from dexmedetomidine administration. For spontaneous movement, which we measured after the rotarod for an hour, subcortical glutamatergic alpha-2A knockouts again showed profound resistance equivalent to the pan-neuronal knockouts to any drug effect from dexmedetomidine. While for this measurement, the adrenergic alpha-2A knockouts were indistinguishable from our FLOX controls. We haven't yet figured out why the GABAergic alpha-2A knockouts showed more spontaneous movement during this period than the adrenergic alpha-2A knockouts or the controls, when by all the other measures, they behaved identically to the controls. We also looked at temperature in response to alpha-2 agonists. And when we measure that temperature after DEX administration, it showed that our subcortical glutamatergic alpha-2A knockouts did not undergo the rapid cooling that's usually associated with alpha-2 agonist administration, while the GABAergic knockouts did and looked identical to flux controls. The adrenergic knockouts showed slightly less cooling than the controls, but we suspect that rather than the active cooling by the preoptic neurons in response to alpha-2 stimulation that's previously been described by the Franks and Wisden group, that this slight cooling may be related to changes in brown adipose tissue metabolism, but we haven't yet done the necessary experiments to test that theory. We also looked at frontal EEG spectra, and these images are from over secondary motor cortex to see whether the behavioral changes we see are mirrored in EEG changes. And these are examples of individual spectrograms for each genotype before and after dexmedetomidine administration. And in our flux controls, we see the expected increase in delta power and dropout in gamma power, while the adrenergic alpha-2A knockouts still do have a drop in gamma power. There's less of an increase in low frequency power compared to other controls. Now, with both the subcortical glutamatergic and the pan-neuronal alpha-2A knockouts, we see little of any changes in response to dexmedetomidine administration on the EEG. And while those were individual spectrograms, when we look across animals rather than individual examples, and I'm showing the difference between drug and baseline on the left and the normalized to total power difference on the right, we see that while both the flux controls and adrenergic alpha-2A knockouts have an increase in delta and decrease in gamma, the adrenergic knockout is attenuated compared to the controls. The subcortical glutamatergic and pan-neuronal alpha-2A knockouts, in contrast, show very little changes in power after dexmedetomidine administration. So on the whole, these changes in the EEG spectra are reflecting the behavioral changes that we saw. So to summarize our findings briefly, that both behaviorally and on EEG, alpha-2A knockouts in subcortical glutamatergic neurons appeared fully resistant to the sedative hypnotic, as well as the temperature regulating effects of alpha-2 agonists. And alpha-2A receptor knockouts in adrenergic neurons showed partial resistance to the sedative hypnotic effects of alpha-2 agonists. And taken together, we believe this shows the direct effects of alpha-2 adrenergic agonists on both adrenergic and subcortical glutamatergic neurons contribute to sedation and hypnosis by alpha-2 agonists. And I'd be remiss if I did not thank my mentors, my collaborators, the amazing techs and students in my lab, and my funders. So thank you, and thank you for your time, and I'm happy to take questions.
Thank you. I don't see any questions in the chat box, but a couple of questions for you here. Have you looked to see what compensatory changes there are in other neurotransmitter receptors, et cetera, in your model? But for example, if you just even did whole brain analysis to see if knocking out alpha-2 versus glutamatergic receptors causes compensatory increases in other things. Same thing for your GABA knockout as well. Just to sort of understand if there's this cross-play.
Yeah, no, that's an excellent question. We haven't yet characterized whether there's, say, a compensatory change in maybe the alpha-2C receptors, which is definitely a possibility. They're also located centrally. There are some alpha-2Bs, I think primarily in thalamus, but we haven't yet characterized the non-alpha-2A receptors and what compensation may occur. I think our first step was to look to see if there were any behavioral differences just in regular behavior, and we're going to characterize some of the sleep-wake and then go on to see if there are other differences at the cell level that are reflected by those behavioral differences.
Sure, from has a question on the chat box. Any speculation as to which subcortical glutamatergic neuronal subpopulations are responsible, or do you think it's more global?
That is an excellent question. And so the next stage in our investigation is going to be doing a virally driven vGlut to specifically knock it out. I would be lying if I said we've got a definite population that we're looking at. We're exploring a number of areas. I would say the ones that are prominent in my thoughts would be, we're going to look at, I'm thinking thalamic contributions may be significant given the large amount of adrenergic output to thalamic regions. The other large area that we're going to be taking a look at is some of the basal forebrain, but that is a very interesting question, something we're actively investigating right now.
Okay. Any other questions? So we still have a few moments. Is that correct, Kristen?
I think we have another minute. So Andrew, I'll follow up with one last question then. I guess I'm surprised, given the results of Korea Sales and Mervyn Mays, that you didn't highlight more caudal structures. When they injected dexmedetomidine in the vicinity of the LC, it appeared that they got a complete dex-like state. So I'm just wondering if you could comment.
Yeah, no, they both were able to reverse with an antagonist and induce with the agonist locally. And certainly one of the things we'll look at with the glutamatergic specific viral knockout is something in the rostral pons as well. I think there's also the possibility, given the location of the LC next to the fourth ventricle, that if we see another structure near to a ventricle, it's quite possible that drug was actually transmitted via the ventricle to another one of those structures. So that may be a result as well.
Thank you. I think we'll stop our questions here and move on to our next presenter.
Thank you.
Today, I'll present results showing that ketamine mitigates sevoflurane-induced persistent memory deficits and a potential underlying mechanism in a mouse model. I have no conflicts of interest. Perioperative neurocognitive disorders occur commonly after anesthesia and surgery. They are complex, multifactorial disorders that are not well understood, and there are no effective pharmacological treatments. Recently, ketamine has emerged as a prevention strategy. However, results from clinical studies are inconsistent. Thus, it remains controversial whether ketamine can mitigate these disorders. We ask whether ketamine has cognition-sparing properties. If yes, it is important to identify the underlying mechanisms. One potential mechanism for persistent memory deficits after general anesthesia is increased GABAA receptor function. Preclinical studies have shown that exposure to a general anesthetic drug triggers an increase in the function of alpha-5 GABAA receptors. This increase persists long after the drug has been eliminated and contributes to persistent memory deficits. Based on these findings, we proposed two hypotheses. First, co-treatment with ketamine prevents memory deficits that persist after sevoflurane anesthesia. Second, ketamine also prevents the sustained increase in GABAA receptor activity. Male and female mice were treated with sevoflurane for 2 hours of vehicle gas. 24 and 48 hours later, we studied recognition and spatial memory, respectively. Separate groups of mice were co-treated with a subanesthetic dose of ketamine or vehicle. We assessed memory by taking advantage of the fact that mice, similar to humans, like novelty. They spend more time with a new object or an object in new location. To quantify this preference for novelty, we calculated the discrimination ratio. If mice remember, the ratio will be greater than 0.5 for the recognition memory assay and greater than 0.33 for the spatial memory assay. We found that vehicle-treated mice showed recognition and spatial memory as evidenced by discrimination ratios greater than chance levels as indicated by the dashed lines, whereas sevoflurane-treated mice did not. Mice co-treated with ketamine and sevoflurane regained recognition and spatial memory. Ketamine alone did not alter recognition or spatial memory. To study GABAA receptor function, co-cultures of mouse cortical astrocytes and hippocampal neurons were treated with sevoflurane or vehicle for 1 hour, with and without ketamine. The drugs were then washed out, and 24 hours later, the function of GABAA receptors was studied by recording wholesale tonic current from neurons. Sevoflurane treatment increased the amplitude of the tonic current generated by GABAA receptors. Co-treatment with ketamine prevented this increase. Ketamine alone did not modify the tonic current. In conclusion, ketamine prevented persistent memory deficits after sevoflurane anesthesia, and also prevented the sustained increase in GABAA receptor function in hippocampal neurons. These results suggest that it might be worthwhile revisiting the clinical utility of ketamine in preventing perioperative neurocognitive disorders in patients. Thank you for your attention.
Thanks for a really exciting talk. I'll kick off the questions for this presentation. When I tend to think of ketamine, I tend to think of a drug that has the potential to induce a lot of neuroplasticity. And yet in this example, you're showing us that the co-administration of ketamine prevents the upregulation or changes in the GABAA receptor. So if I followed correctly, your co-culture work suggests that ketamine's actions may be possibly cell autonomous, or at least not require distant projections. And I'm wondering if you could provide any more insight on sort of the steps through which ketamine blocks the adaptation in the GABA alpha 5 receptor.
Thank you. That's a very excellent question. I want to clarify that at the beginning of the video, I did have a brief introduction, and for whatever reason was cut off. I did say my name and the title, those things. This is a great question. So to clarify, we did in vitro studies to follow up on our previous findings, which show that when we treated co-cultures, there's a persistent increase in alpha-5 GABA receptor mediated tonic current. In this study, you found that ketamine actually can prevent that persistent increase in tonic current. Because it's a co-culture, you're asking the potential mechanism for this prevention effect of ketamine. We do have some preliminary results showing that ketamine actually can either act on astrocytes or neurons. It's also not NMD receptor dependent. It's sort of through BDNF and GSK3 beta can have this persistent effect. Hopefully I answer your question. If you could have further discussions.
So it looks like we have
a couple of questions on the chat. Max, I'm happy to read them. Dr. Lim says, what is the translated human dosing schematic that parallels your experimental dosing schematic?
So let me see. So I guess the question is asking the doses of ketamine. In terms of doses I use, compare in comparison with the clinical dose. Obviously, the dose is important. For the in vivo behavior study, we did intraperitoneal injection at a dose of 10 milligram per kilogram. From the literature, the anesthetic dose for ketamine is between 75 and 100 milligram. If anyone uses the ketamine to anesthetize an animal together with xylazine, we use 10 milligram, which is sort of at a sub-anesthetic dose of ketamine. For in vitro culture study, we use 10 macromolar, which a lot of literature show the ketamine in slice or cell culture model, the dose is between, it's a wide range, relatively wide range between 10 to 50 macromolar, if I can say that.
Dr. Mashur has a question. An in vivo study in rodents showed that addition of subanesthetic ketamine to a halogenated ether accelerates emergence and increases cortical acetylcholine compared to saline control. So could cognitive function have been improved due to increased arousal or non-GABA mechanisms?
So I'm not sure. Can you say the question again? I'm sorry.
So could the effects that you see be due to cognitive function having been improved due to increased arousal that occurs because of the combination of halogenated ether and ketamine, or to non-GABAergic mechanisms?
That's a good question. I have no answers for that. That's a potential possibility, I guess. Yeah, and we have to keep in mind is the body is pretty complicated, even in our co-culture system, and this mechanism that we found. It cannot be just single mechanism, and it might be some multiple mechanisms acted in a concerted way. That's all I can. The arousal thinking is a very, very good question, good point.
Okay. Dr. Taufik has a question. Do you have a sense of the effect of shorter exposures, i.e. less than 15 minutes? And how long do such effects last?
Again, it's a very good question. We did not do any timeline studies. For example, the ketamine treatment, we only co-treated with sevoflurane culture for 1 hour, no other timeline. And in terms how long this effect can last, we do not know. We only record 24 hours. Obviously, those are good questions. It's on our radar for future studies. So very good. We are thinking about those questions as well.
Okay. And Dr. Shi has a question. Any effect on alpha-4 subunits?
That's great. If you talk about extrasynaptic, this is a very obvious question. We argue about alpha-5, but we do not have evidence to show this tonic current is completely mediated by alpha-5 GABA receptors. Another major subtype of extrasynaptic GABA receptors, which mediate tonic current, is alpha-4 subunit containing. Is it possible? In hippocampus, those are the two major subtypes, GABA receptors which contribute to tonic current. It is possible.
Okay, thank you. I think because we are running out of time, there are a few more questions for you in the chat box. If you can address those in the chat itself, that would be very helpful. Sort of keeps the conversation going. Okay.
Okay, no problem. Thank you.
Thank you.
Thank you, everyone.
Thank you for the opportunity for me to present the abstract in the topic of incident and predictors of a same-day case cancellation. My name is Perelman from Department of Anesthesiology, Montreal Medical Center. I have no conflict of interest to be declared. So for the background, cancellation of scheduled operation on the day of surgery has negative effects. Patients don't get the treatment and surgical services don't get paid. There is no prediction instrument that clinicians could use to forecast the risk of same-day case cancellation. What we have already known is that there are many factors that matter in terms of same-day case cancellation. For example, patient-related factor, patient anxiety, new onset of patient's illness, or even patient don't show up in the day of surgery. Posture-related factors, we have already known that some specific surgical services has a higher risk of cancellation more than the others. Facility-related factors, for example, staffing issues or no operating room time. We conducted a retrospective cohort study, which included more than 200,000 scheduled elective procedures between January 2016 and June 2021 in multiple healthcare system. We excluded procedures conducted in March to June 2020 when elective surgical was canceled due to COVID-19. Same-day case cancellation was defined as the cancellation of a scheduled surgical procedure within 24 hours of the scheduled date and time. So our parity-defined candidate predictors were included in a multivariable logistic regression model. Backward stepwise regression was performed with a cutoff p-value of less than 0.05 for retaining predictors in the model. The model was subsequently internal validated utilizing cross-validation. Here are the main results. Let me walk you through these slides. So on the right-hand side, the individual predictor with the point value was shown. So you can see that the strongest predictor was a history of anxiety and opioid prescription. Other important predictor was high BMI. For example, if you schedule a 65-year-old obese African-American male with history of anxiety, this patient will have the score of 25 points, which predicted more than 30% of cancellation rate. And if you schedule this patient for inpatient vascular surgery, this risk will increase to more than 50%. So our model was well calibrated with the observed same-day case cancellation rate here and with the area under the curve of 0.8. So in the conclusion, we developed a prediction instrument for same-day case cancellation that can be applied preoperatively. This score will be used during preoperative assessment to identify the high-risk patients, and we will have the implementation, the intervention dedicated to decreasing same-day case cancellation. For example, we will enhance patient engagement and patient education to address all the anxiety issue. We will have multiple steps to communication with the patient. For example, we will do the preoperative phone call or mobile application. And we also have a plan for patient transportation issue. Thank you so much for your attention.
So perhaps while we wait for questions to pop into the chat box, I'll kick one off. It looks like you've done a really impressive analysis of nearly 250,000 patients and the reasons why they might be canceled. I guess I was curious if you could comment on whether these cancellations were occurring because of physicians deeming the patient not optimized, or given the role of anxiety that you showed, are these patients that didn't show up on the day of surgery?
Yeah, thank you for your question. So we quite done differently. So we found that in the literature that we have all of the reason that you mentioned in the same day case cancellation, right? Like the patient factor and the surgical factor or DOR scheduling factor or all those type of things. But compared with the no-show, they have the model for no-show prediction of the patient, but for the same-day case cancellation itself, there is nothing in the literature review that I reviewed that they have no model to predict that. So what we did, we tried to find we try to take all of that lesson into an account and try to put it into the model. And if it retained in the model, we just calculate it as the score. So we try to implement this one, calculate this one first, and then we will implement it and look into the reason. So I didn't look exactly what reason of case cancellation in our institute, like what is the main reason, something like that. Yeah, this is just a prediction score.
Prakash, you're muted.
There's a question in the chat box. What is your overall cancellation rate on the day of surgery? This is from Dr. Epstein.
Yeah, 8.4%.
Okay.
Mm-hmm.
And Dr. Orso has a question. Can you comment on the role of your pre-op assessment clinics in reducing cancellations?
Yeah, that is what we are trying to do like now. Then we have the score we validate internally, and then we try to improve our preoperative assessment clinic program. Like we will apply this case cancellation score, and we have another score like ASA prediction from machine learning, something like that, to just classify the patient as a high risk. If the patient has a ASA more than 3 with some specific surgical procedure, or ASA more than 4 or higher list of case cancellation more than 25%, we will send them to the PAT visit. And that is our plan.
So other questions, people can put in the chat, and Dr. Wong Tungman can answer those. Okay. Actually, Dr. Epstein has a question. Can you repeat the percentage? Did this include both inpatient and outpatient cancellations or just outpatient?
So the overall percentage is 8.4, but the outpatient cancellation is 8.3. It's not quite so much different. Yeah, outpatient, I mean ambulatory surgery cancellation, not same day admission, something like that. Yeah.
Okay. I think there's a number of questions that are coming up that perhaps you can answer through the chat. Okay. Yeah. Thank you so much for your presentation and questions and answers.
So the PAT visit previously, before COVID, we did in person, but like during and after COVID, it turned out to be virtually. Yes, PAT visit from the question.
We can plan on answering the rest of them through the chat only, and we can move on to the next talk. Okay. Yeah. Thank you. Yeah.
Hello, everyone. I'm Megan, a medical student from the Duke University School of Medicine. Today, I will be discussing cognitive and cerebral spinal fluid Alzheimer's disease biomarker changes in older surgical patients and matched non-surgical controls. I'd like to thank Dr. Melody Reese and Dr. Miles Berger for their mentorship, along with everyone else on here for their contributions to this project. I have no disclosures to report. There's debate over whether anesthesia and surgery contribute to long-term cognitive decline in older adults. This has remained an important area of research, as approximately half of adults over 65 will undergo at least one surgery, and our population is continuing to age. Studies show that post-operative cognitive dysfunction occurs in as many as 43% of older adults within a week after surgery and still has impact 5 years later. One way in which surgery may promote cognitive decline is by accelerating Alzheimer's disease pathology. In mice, surgery under anesthesia promotes amyloid beta plaque formation and tau phosphorylation. In humans post-off CSF, tau levels can rise into the range seen in Alzheimer's disease. On the other side, researchers argue that surgery does not provoke cognitive decline, citing negative studies and highlighting other limitations such as small sample sizes, lack of randomization and controls, and use of retrospective analyses. Thus, it remains unclear to what extent cognitive decline is due to underlying disease processes rather than perioperative care itself. To further clarify the relationship between surgery, cognition, and AD biomarkers, we performed a prospective study in which we performed neurocognitive testing and measured CSF AD biomarkers before and after surgery in surgical patients and at the same time intervals in matched non-surgical controls. We hypothesized that 1, CSF AD biomarker pathology would be greater over time in the surgical group compared to the matched non-surgical controls, and 2, cognition would be worse over time in the surgical group compared to the controls. We prospectively enrolled 140 patients aged 60 or older undergoing major non-cardiac, non-neurologic surgery under general anesthesia for at least 2 hours. We did not include cardiac or neurologic surgeries because cardiopulmonary bypass, vascular disease, and direct manipulation of the dura can confound cognitive and biomarker results. We also enrolled 51 non-surgical controls who were matched to the surgical cohort based on age, sex, and years of education. CSF samples were obtained by lumbar puncture at baseline, 24 hours, 6 weeks, and 1 year, and measured for levels of A-beta 42, total tau, and phosphorylated tau. Cognitive testing was administered at baseline, 6 weeks, and 1 year. Cognitive performance was measured by the continuous cognitive index, a weighted average of multiple individual tests in our test battery. We had 107 surgical patients and 46 controls for analysis at the 6-week time point. When examining patient characteristics, we found that the groups were well matched by age, sex, and years of education as intended. However, the surgical patients had lower attention scores at baseline, and also most notably, a significantly higher percentage of controls had CSF evidence of AD pathology at baseline as measured by levels of A-beta and tau in their CSF. CSF testing also showed that non-surgical controls had greater tau over A-beta increase at 24 hours and a greater tau and A-beta increase at 6 weeks, thus suggesting that surgery is not associated with a harmful change in AD biomarkers. The findings may also indicate that the control cohort contained more individuals with latent brain abnormalities, such as neurovascular dementia. In univariate and multivariate analyses of continuous cognitive index change at 6 weeks, there was no difference between surgical patients and controls. However, when we took the cognitive analysis out to 1 year, there were greater differences. Here you can see both groups had lower cognitive index scores at 1 year relative to baseline. Group, time, age, years of education, AT positivity, race, and sex were all significant factors. Most variables had the impact that was expected. For example, the surgical group had lower cognitive index, increasing time led to more decline in cognitive index, and those with AT positivity had more decline in cognitive index. However, when the interaction of group and time was taken into account, the surgical group ended up with a higher cognitive index than the controls, which is the opposite of the expected outcome. This may represent the mismatch in controls and bias in attrition, as 27 surgical patients and 6 controls had withdrawn by 1 year. The study represents one of the largest cohorts of older surgical patients who underwent cognitive testing and CSF measurements with matched controls. We showed that non-cardiac, non-neurologic surgery does not accelerate CSF AD pathology or cognitive decline within 6 weeks. Differences in cognition between groups were seen at 1 year, but results may be unreliable due to bias and attrition. Also, we showed this type of study is difficult to perform since we found that groups with matching demographic information may still have significant differences in underlying AD pathology. There are many determinants of cognition that couldn't be accounted for here, and we need careful consideration of these factors when designing future studies to produce more reliable results. These are my references, and I'm now happy to take any questions. Thank you.
Thank you for a really phenomenal study and a great presentation. I want to follow up on one of your concluding points about how difficult it is to conduct this type of research and ask you to tell us a little bit more about the control group. I'm guessing you tried to pick normal, healthy aging controls, but I'm wondering if you can say more about them.
Yeah, so thank you so much for your question. Great question. So the control group was mainly healthy people. They were recruited separately from the surgical group. So it wasn't like we went to clinic and found people who would have had the same surgery but didn't get surgery. It was more of from existing registries that we had from other Alzheimer's and cognitive research that we've done, and flyers throughout the hospital. And that's mainly how we got them. And then due to the limited funding, we could only recruit about 50 of them. And that's why we strata-based matched them. So we had a group of 60 to 64, 65 to 69, 70 to 74, and then greater than 75. And then we tried to find people in those categories and match them to the surgical group.
Quick question, what would you have done differently if you had to redesign the study?
That's another great question. I think one thing that would have been helpful is, again, if we could get more controls and more surgical patients and find a way to keep people coming to the follow-ups and getting all those throughout 1 year, because it's very hard with this type of study, especially getting people to get LPs, to get them to keep coming back, which I think it's great that we were able to get as many people as we did, but then it makes it harder to interpret our results. And I guess another thing would be if we could look more at the patient's comorbidities ahead of time before doing the matching, and maybe try to take more of that information into account, because we can't just randomize people to have surgery or not. So if we could take into account more of those things, that might have been helpful.
Okay. So question in the chat from Dr. Epstein, were you able to determine the reasons for attrition?
That is not something we looked at, so I do not know.
And from Dr. Orser, did you observe any patterns regarding the severity of cognitive deficits and biomarker levels?
Yeah, that's another great question. We didn't look at the patients at an individual level, so we can't really say, if someone had more cognitive deficit, what their biomarkers levels were. We kind of looked at everything on a group level, but also we didn't see a whole lot of change at a group level in terms of the biomarkers. So we couldn't say a whole lot about that correlation.
Dr. Berger has a comment. Sorry, it sort of went off my screen. Would also add that one could try to match based on baseline cognition, though that would be much harder to do. It would require selecting only some folks as controls out of those who are willing to participate as controls. A question from Dr. Polanka, and then we'll stop. Did you follow pain or depression scores in the perioperative period? Are improvements in these areas an alternative explanation for your effect?
Yeah, so we did not follow these directly. We did have a lot of questionnaires that the patients filled out before and after, and some of these got at things related to depression and related to pain, like how your mobility was at home, how you were feeling, how many days you were feeling down, things like that. So we had that information, but that is not something that we analyzed. But yes, that is something that may explain the effect in the surgical cohort, because some of these people, if you're getting orthopedic surgery and you're having a lot of pain ahead of time, but then after the surgery, you have more mobility, you're able to do more exercise, that can improve cognition.
Okay, good. Thank you, Ms. Wong, but make sure to address all the questions that are being addressed towards you in the chat, okay? Thank you so much.
Thank you.
Hello, my name is Andrew Bashara. I'll be speaking with you today about a machine learning model to predict post-operative opioid refills as a screening tool for referral to a transitional pain clinic. The other authors and I are from UCSF, and Dr. Albrecht here is in the initial stages of setting up a post-operative transitional pain service clinic to minimize likelihood transitions from acute pain to chronic pain after surgery. Today, I will be speaking about the machine learning component of our model that we developed and validated and why we believe it achieves adequate accuracy for predicting which patients might be considered in initial screening for this clinic. Here are my financial disclosures. As an introduction, transitional pain service clinics have been recently proposed as a way to reduce persistent postoperative opioid use by providing acute pain care for recently post-surgical patients at elevated risk of new persistent opioid use or transition to chronic post-surgical pain. Identifying which of these patients may benefit from TPS evaluation within 2 months postoperatively is a challenge. However, because there are no validated models for predicting which patients are at risk of prolonged postoperative use prior to pain chronification at 3 months postoperatively. To identify opioid naive patients who might benefit from a TPS approach at our institution, we leverage local data available in the electronic medical record to predict postoperative and post-discharge opioid refills during a transitional period defined as the days between 30 and 89 days after surgery. That way, we can use this model to allow surgeons to refer patients to the TPS clinic. Here are the methods we use to develop our model. This model is a retrospective observational study of about 39,000 opioid naive patients aged 18 and older, surgical procedures at UCSF from 2012 to 2019. IRB was approved. And we used extreme gradient boosting machine learning algorithm with the specific hyperparameters shown below, which were found using grid search CV. We calculated the confidence interval of the receiver operating characteristic area under the curve with a 6-fold cross-validation, which is shown here. The mean AUC was 0.75 plus or minus 0.01. And as you can see, the standard deviation and each of the individual ROC curves are pretty close to the mean. As such, we were able to use one of these curves as a representation of the mean and take 80% of the sample, total sample, and train the model, and then use 20% to build a calibration plot, which shows generally close predicted probability to the true probability in each bin of patients, meaning that the model predicted patients who were likely to have postoperative opioid use to be high probability of having postoperative opioid use, suggesting that it discriminates well and gives a good probability estimate. Using the same model, we are able to look at which variables were most important in prediction. We used Shapley additive explanations, also known as SHAP, as a tool to build this picture that shows the representation of the value of each of the variables and the likelihood prediction. The important variables in the model included opioid prescription during 0 to 30 days. Note that the first variable says no. So the high value in this case is actually that the patient did not need a postoperative DC order from days 0 to 30. Total number of oral morphine equivalents needed on the day prior to discharge, discharge disposition, postoperative length of stay, and total OME ordered at discharge, age, and total length of surgical case. You can see that in this graph, specifically if we look at DC day -1 oral morphine equivalents total dose, that is the total oral morphine equivalence the patient needed on the day prior to discharge. With high values, the red value, that increased the likelihood, because it was on the right, that the patient would be predicted to need a postoperative prescription from days 30 to 89. If they had very low need on their day prior to discharge, then the model predicted, in this case blue, then the model predicted that they would likely not need postoperative prescription from days 30 to 89. Hence, the blue is on the left side of that chart. And as we read down, we can see a general correlation and matching with our understanding of physiology, with some mixed variables such as age, where it seems that there is a bimodal distribution. Here are our references, and thank you very much.
So Dr. Bashar, I have a question while we wait for the chat box to fill up. I was hoping you could clarify the number of patients in your study that go on to consume opioids in that 30 to 90 day window, what fraction do, and beyond that, how much of the variance does your model explain in predicting those who are at risk?
So for the first question, it was 9%. So about 3,500 of those 39,000. And can you repeat your second question, Dr. Kels?
Sure, absolutely. So I was interested in how much of the variance or variability does your model predict? How good is it at using these factors and saying patient X is going to be a long-term opioid consumer?
So measuring the variance with machine learning, we went straight to the machine learning because we anticipated that would probably benefit. We didn't do a lot of the variance calculations that I'll normally do to describe population. But extrapolating from the accuracy of the model, I would say it covered, especially the calibration curve, it covered most of the variance, except in the middle section, where probability was kind of 0.1 to 0.2, so 10 to 20% chance. It didn't do as well there, and you would expect that those patients who are kind of in the middle cusp, that they might have a lot of varying reasons, maybe more social factors that might not be as captured in the model. So at the very low probabilities and high probabilities, the model did quite well.
Sorry, I'm trying to catch up with the. Okay, so Dr. Lim has a question. What does a transitional pain clinic look like for your institution? When do you meet with them? How often? And what are your interventions?
That's a great question. So we're very much in the early stages. We have not set up the clinic at all. And this is one of the steps towards trying to figure out the optimal way to set up the clinic. I was actually asked by, I'm not a pain doctor, but I was asked by the pain doctors to set up this ML model because one of the biggest things standing in the way of making this happen is that too many patients would be sent over to that clinic, and they're already kind of having issues with the current pain clinic of just not being able to see all the patients. So basically this is to stratify which patients we would see.
Okay, I think the other question is not related to your talk. Any additional questions from the group? If not, then please continue monitoring the chat in case there are any additional questions, Dr. Bishara. And thank you so much for your presentation.
I will. Thank you very much.
Good morning. I'm Kathleen. I'm a postdoc in Dr. Soul's lab here at Mass General, and I'm really excited to share with you today some of our ongoing work investigating the role of dopaminergic midbrain neurons in post-anesthetic cognitive recovery using our rat models. And I have nothing to disclose for this presentation. So to study cognitive function in rats, our lab uses these touchscreen-based operant conditioning chambers, and specifically today I'll be talking about the 5-choice serial reaction time task, where we train animals to perform a task that assesses aspects of sustained attention, working memory, inhibitory control. And by assessing these higher order cognitive domains, we can determine how long it takes for animals to recover cognitive function following general anesthesia. And we do this by placing anesthetized animals unconscious in these chambers, waiting for them to wake up as measured by the return of the writing reflex, and seeing how long it takes for them to be able to perform this task with a high degree of accuracy and a low degree of omission, 2 measures associated with the cognitive function. Now, what we've learned from past experiments is that the recovery of cognitive function is significantly dictated by the anesthetic used. For instance, following isoflurane, sevoflurane, or propofol-induced anesthesia, cognitive recovery is incredibly quick following writing in young, healthy rats. If you contrast this to ketamine and dexmedetomidine, the recovery of cognitive function was significantly delayed following conscious recovery. In fact, even 3 hours after rats have righted, a lot of them don't recover the ability to perform this task. What governs this trajectory is currently unknown. However, we want to investigate some significant circuits that are involved in both anesthetic emergence, but also cognition. So the one we're looking at today are the dopaminergic midbrain neurons. Our lab has studied them extensively. We know that pharmacological manipulation and electrode placement into the ventral tegmental area can accelerate or induce anesthetic emergence in rats. But these circuits are also known to be involved in motivation and reward and attention-associative learning. So we wanted to target these circuits and see if we can accelerate the cognitive recovery following anesthetic emergence. So to do this, we use this dual viral targeting strategy. One virus contains the rat tyrosine hydroxylase promoter to drive Cre-recombinase expression in dopaminergic neurons. The second virus contains a Cre-dependent designer receptor exclusively activated by designer drugs, or DREADs. And we use the activational DREAD HM3DGQ, tagged with an M-cherry reporter. And these receptors are G-protein coupled receptors that are activated by clozapine N oxide. And you can see from the histology that we can get some widespread expression of these DREADs in these dopaminergic midbrain neurons located around the ventral tegmental area. So after these animals have these receptors expressed, we can then expose them to dexmedetomidine and ketamine, and then either to saline or CNO, and determine whether or not we can move forward this cognitive recovery trajectory by activating these circuits. And here's a video of the same female. She is given saline and CNO following dexmedetomidine-induced unconsciousness. And here she is an hour after being placed in the chamber. She's writing around the same time in both cases, and she immediately tries to start the task with a nose poke into the food tray. Now, immediately after they wake up, they're not coordinated nor cognitively functional enough to perform this task. But you can see that by half an hour after writing, the animal who's given CNO is back at playing the task, getting her food rewards for her efforts. Now, the saline-treated animal, you can tell by the little white light in the corner, which indicates a mistrial or an inaccurate response, is trying to complete the task, but is failing to do so accurately. And in fact, she's missing a lot of the trials. Even an hour after she's been conscious, the saline-treated animal is still having difficulties, while the CNO-treated animal is working well on task. In fact, is close to where baseline activity is, with getting most of the trials correct and missing relatively few trials. And we tested 8 animals, 4 males and 4 females, under
dexmedetomidine and ketamine, and observed that although writing reflex was not affected following dexmedetomidine with CNO, it did significantly accelerate the cognitive recovery. The interesting finding was that the same technique had absolutely no impact following ketamine. You can see the cognitive recovery curves following ketamine under CNO in red and saline in blue essentially overlap. These results suggest that the mechanisms by which cognition recovers following anesthesia is also anesthetic dependent. I would like to thank our lab members and of course my PI, Dr. Solt, and his funding, and thank you all so much for your attention.
Thank you, Dr. Vincent, for a really phenomenal talk and some really exciting work. While we wait for the chat box, I'll ask a question. So your results point to some very provocative suggestions saying that there may be a fundamentally different pattern by which the brain recovers following dexmedetomidine versus ketamine. But I guess before reaching that conclusion, I noticed that the writing reflex times were faster both for your saline and CNO groups in the ketamine cohort compared to dexmedetomidine. So my question is, how do you distinguish if the comparable recovery of cognition in ketamine was simply due to giving a smaller dose and a comparatively smaller perturbation of brain function as compared to potentially the longer half-life of dexmedetomidine?
That's an excellent question. In fact, the dose we gave for dexmedetomidine was the lowest dose possible that we could give and still maintain loss of writing in these rats. In fact, it's 20 microgram per kilogram. And although they stay unconscious for an hour plus, they're still very rousable. So they're not as deeply anesthetized actually as the ketamine, whereas the ketamine animals are not rousable at those doses. And all of the cognitive recovery profiles, what we're looking at is after they've been able to write, sort of comparing from that starting point. So they're all, they're at the same point in terms of they can flip back into a prone position. How long after that does it take for them to recover? And dexmedetomidine generally takes much longer. In our original paper, rats recovered cognitive function a little bit faster after writing from ketamine. But that can't be pushed any further with this brain stimulation technique, whereas with dexmedetomidine, even though cognitive function takes far longer, you can push it towards a faster recovery. So of course, it's the dose is going to make the medicine, but what we're really comparing is we're comparing based on writing, so the same behavioral phenomenon.
It looks like we have another question in the chat box from Dr. Xia, who compliments you for some excellent work and asks if you've tried to use amphetamine to see if that might facilitate cognitive recovery. And if yes, that may be the reason for reversal.
Right. So our lab has obviously done a lot of research showing that amphetamine can stimulate writing from dexmedetomidine, for instance, and a paper from my coworker, Dr. Risako Kato, she actually shows that amphetamine reverses dexmedetomidine, but not ketamine. And we're not sure, and amphetamine actually reverses iso, sevo, propofol, dex. It kind of works across a broad range, pretty much everything we've tested except for ketamine. And that would be interesting. We haven't done a study where we just give them amphetamines to accelerate that reversal from dexmedetomidine. I think it makes sense. Right now I was looking to see sort of the specific pathways because amphetamine's a bit dirtier than using chemogenetic targeting. But if we can see this reliably work using our chemogenetic techniques and using amphetamine, if that were to accelerate cognitive function, that'd be a much easier tool to implement, particularly in patients where you can't, obviously can't do any chemogenetic techniques. But I think that's a great study to do.
And I guess I have one last question if there's time, which is I'm wondering if you can dissociate the motivational component of bringing the dopaminergic system back online from the cognitive component. And I confess that I don't have an easy way to do that, but it is curious.
I think, no, that's absolutely, I mean, ventral tegmental area is known for being that motivational, that reward seeking behaviors. And we actually get a lot of different outputs using these chambers that are automatically recorded. So we can actually see how many trials that they attempt to initiate. So that was one way to measure motivation. Are they trying to initiate trials? Do they really want to get that food? And so that's similar between the two drugs. The other thing I do is because all the animals are food restricted to cause them to be motivated, because rats are not really interested in these iPad games alone. I weigh how much food they eat in the chamber and how much food they will eat in a 1 hour free feeding period after. So if, for instance, they, if they're very motivated to eat under one drug condition, then you might see an increase in food eating. Even if they can't perform the task, they would eat, more food afterwards. So they tend to eat the same amount of food total in the chamber and out of the chamber in both drug conditions. It just seems that, for instance, with ketamine in both conditions, they just can't get any food in the chamber. Whereas with dexmedetomidine, they're able to eat a lot more while in the chamber, and then they don't eat as much later. So it doesn't seem that, at least with those basic levels of assessing motivation, we don't see that as having a huge explanatory factor as far as we can tell. But I mean, that's always a possibility, particularly with these operant conditioning chambers, that is hard to get around.
Okay, well, I'll ask the audience to type additional questions into the chat box, and hopefully Dr. Vincent will be willing to answer those offline. And thank you again for a wonderful presentation and a nice bit of work, and we'll move on to our next speaker.
Thank you.
Thank you all for being here. Today, I will be talking about integrating single-cell and plasma proteomics in order to predict surgical site complications. My name is Amy. I'm a fourth-year medicine at UC Davis, and I'll be presenting my research with the Godelier Lab at Stanford School of Medicine. I have no financial disclosures. Complications occur approximately 1 in 5 surgeries. That means of the 110 million surgeries performed each year in the US and in Europe, there are approximately 22 million complications. Of that, approximately 2.2 million are surgical site complications, and that translates to prolonged personal suffering and significant socioeconomic burdens in the form of longer hospitalizations and readmissions. Postoperatively, a patient's recovery trajectory is complex. That means despite very similar demographics and patients receiving similar surgeries, the development of these complications can vary quite drastically. The current surgical risk calculator, NISCIP, predicts surgical site infections with an AUC of 0.7. For other complications, such as reoperation or readmission, it's not adequate, so an AUC of less than 0.7. As such, perhaps we can integrate the biological parameters that drive the pathogenesis of surgical site complications in order to increase risk prediction accuracy and improve patient care in the long run. Within minutes of surgical injury, there is activation of the inflammasome that leads to a TLR activation by DAMPs, and this results in the secretion of pro-inflammatory cytokines such as IL-1 beta, IL-6, and TNF-alpha. IL-6 in particular activates the STAT3 pathway, and it has been shown to forecast adverse postoperative outcomes, including onset of delirium and mortality. Simultaneously, there is an anti-inflammatory and immunosuppressive adaptation. So dysregulation in either direction increases the risk of postoperative complications, as overt inflammation can lead to SIRS, while profound immunosuppression can predispose a patient to developing post-surgical wound infections or sepsis. The immune response to trauma is very well orchestrated, and it virtually involves all branches of the immune system and engages all these immune cells. Therefore, it's important to be able to study the immune system at a single cell level and understand the function and role these cells play in the development of adverse outcomes. Luckily, this type of high-resolution study is now possible with mass cytometry. So using up to 50 phenotypic and functional markers, we're able to classify most of the major innate and adaptive immune cell subsets and quantify their abundance. We can then look at each of these populations in detail and study their function. So their endogenous response, or how they can respond to cytokines such as LPS, interleukins, or interferon alpha. That we can then form a network of all of these immune cells to understand holistically how the immune system responds to immunological insults such as surgical trauma. This brings us to the goals of taking this technology in order to improve predictive performance. So we hypothesize that single cell and plasma proteomic elements of a host's immune response to surgery can accurately identify patients who will develop a surgical site complication after major abdominal surgery. We recruited 41 patients for this study, and 11 patients developed a surgical site complication, which is defined as either a surgical site infection, an anastomotic leak, or wound dehiscence within 30 days of surgery. Blood samples were collected before surgery as a baseline sample, as well as on postoperative day 1. The whole blood samples were either left unstimulated for endogenous activity or stimulated with cytokines, and then analyzed using mass cytometry. In parallel, 272 proteins from the plasma were quantified using Olink. So mass cytometry produces a high-dimensional data set with very complex and interrelated processes that require advanced machine learning methods. In simple terms, we created elastic net models for each of the 9 data layers in order to predict the development of a surgical site infection. We then integrated them using a stack generalization method in order to yield a final predictive model. This model classified patients with a high accuracy, so an AUC of 0.86, and it remains predictive of surgical site complications when accounting for patient group differences such as surgical duration or use of biologics like TNF-alpha inhibitors. To delve into the biology a little bit more, certain pro-inflammatory proteins were elevated in patients who develop a surgical site complication. This includes STREM1, which is an enhancer of the TLR4 pathway, as well as LIF, which is an IL-6 family cytokine. Other proteins were actually decreased in patients with a surgical site complication, and this includes EIF5A, which is implicated in T cell activation and autophagy, as well as KRT19, which is involved in epithelial cell differentiation, particularly of the colonic mucosa. And this suggests that patients at risk of surgical site complications may have impaired healing. I'd also like to highlight a couple specific immune cell features. So consistent with prior findings, STAT3 activity in classical monocytes is activated in patients who will develop a surgical site complication. Remember that the STAT3 pathway is activated by IL-6. So when coupled with the elevated LIF levels in these patients, this suggests that activation of the canonical pro-inflammatory pathways is more pronounced in patients who will develop a surgical site complication. Additionally, the abundance in the STAT3 signal was elevated in immunosuppressive MDSCs, which suggests that unchecked systemic activation of an anti-inflammatory immune cell subset in response to surgical trauma can contribute to the development of a surgical site complication. And this is reflected in the adaptive immune branch. So in summary, the complex interplay between pro-inflammatory and immunosuppressive cellular mechanisms after surgery differed between patients who develop a surgical site complication from those who don't. This difference is detectable as early as 1 day after surgery and is harmonious with current theories on surgical site complication risk factors. However, we had these baseline pre-surgical samples and we wanted to ask the question, can we predict if a patient will have a surgical site complication before surgery? And the answer is yes. So we applied the same analysis algorithm to the baseline samples collected before surgery, and the resulting model accurately differentiated the 2 patient groups with an AUC of 0.82. This model actually improves to an AUC of 0.94 when integrating parameters from the ACS risk calculator. This leads us to our current clinical trial on prehabilitation, where patients were recruited and enrolled in a rigorous 3 to 6 week prehabilitation program in which their fitness, nutrition, meditation, and cognition were optimized. Preliminary data from this study has shown improvement in some surgical outcomes. So in conclusion, CyTOF analysis revealed key immune responses that mediate important adaptations in the development of surgical site complications. Multivariate analysis was able to produce models more predictive of these complications than the current gold standard. The models remain significant when accounting for confounding factors. And finally, this is a promising avenue for guiding preoperative interventions such as prehab or surgical timing. Finally, I would like to thank the amazing team that I had the opportunity to work with in order to make this study happen. And thank you all so much for listening today.
Thank you, Ms. Tsai. That was fascinating. Couple of questions off the bat. One is, I appreciate that, of course, the immune cells and, the immune system is the one to look at. Can you imagine of ways to look at the surgical site itself and follow it pre-op versus post-op in specific sort of areas to sort of understand immune cell, resident tissue interactions in the context of how this inflammation and surgical site infections might occur? Thanks.
Yeah, actually, that's a really interesting question. It was something that we did want to explore in the first place. All of the assessments were done with a clinical team, and it was actually done by like a completely separate team. And in the end, it was really difficult to get tissue samples and to get all of this ready. And so that's actually what we're doing in our next study, because while we were trying to do this study, we were still trying to optimize the imaging mass cytometry assays, which we didn't have at the time. And so we thought maybe we'll pass on this for now and then revisit in the future.
Dr. Berger has a question in the chat. Could you comment on why you all decided to use the Olink for proteomics rather than mass spec-based methods?
My understanding is Olink is just able to do a very like it can canvas like thousands of proteomics within just 1 cc of plasma. And so that's why we ultimately chose it. I'm not sure why we didn't look at mass spec. It was, yeah, we had really good results with Olink in a lot of our previous studies. So we just decided to continue using it.
So it's interesting to see the CyTOF analysis. Are there limitations to how many parameters you could look at? And of course, there's always the sampling problem, right? You've got one time point. Are there other sort of emerging technologies that we can potentially use for more dynamic predictions? Because CyTOF does take time, right? A lot of time.
Yeah. So I think what's nice with CyTOF is it allows you to canvas the entire immune system really broadly because it allows so many parameters. And then once you identify enough features of interest, we can reduce it down to flow, which is just so much faster, and you have sample preservation and all that stuff. So and it also is a lot more affordable. So that's kind of what we're trying to do is, can we downscale the analysis and make it just a little bit more cost effective?
Good. And Dr. Long has a question in the chat. So, did you try entering the clinical parameters for the individual approximately 40 included patients into the NSQIP calculator to see where the model produced concordant versus discordant predictions for specific patients?
Yeah, so I don't have the numbers off the top of my head. We do have this, and most of it was actually so the AUC is quite low for predicting certain features. It's like an AUC of 0.6 for some of the outcomes that we were looking at. So I actually, so I don't really know the numbers off the top of my head, but it probably wasn't significant if I can't remember.
Okay. And of course, there's the important question, are you going into anesthesiology?
Yes, I am going into anesthesia. I actually just matched on Friday, so I will be going to Stanford.
Congratulations.
Thank you.
Congratulations. Any additional questions? Good. Then thank you, Ms. Tsai, and soon to be Dr. Tsai. And we'll move on to the next talk.
Thank you, guys.
Hello, my name is Christian Gay, and today I'm going to be speaking about phase-locked acoustic stimulation and how it can increase human thermal arousal thresholds during dexmedetomidine sedation. Disclosures for this talk include funding from the McDonnell Center for Systems Neuroscience at Washington University in St. Louis, a pending patent on some of the methods I'm going to discuss, and the fact that the presentation does include discussion of the investigational use of a novel device. I'd like to acknowledge my collaborators at Washington University, MIT, and Imperial College London. So we're going to start with a short discussion of EEG slow delta waves. You can see them here on an intraoperative monitor. In the bottom waveform, referring to these large amplitude oscillations in the EEG, which occur at approximately 0.5 to 4 hertz frequencies. Now, these oscillations are not only seen during general anesthesia, we also see them during natural sleep, as well as propofol and dexmedetomidine sedation in the intensive care unit. Now, these slow oscillations have been found to actually correlate with states of consciousness, not only drug concentrations. And this was revealed in a series of experiments where participants were sedated with propofol and or dexmedetomidine and then aroused. And what the investigators found is that despite maintaining steady state concentrations of the drugs, the patients or the participants lost their EEG slow oscillation power in their EEG when they were aroused, suggesting that these waveforms are actually a reflection of states of consciousness rather than simply a reflection of drug concentrations in the brain. And so then the question arises, can we enhance these slow oscillations using methods other than pharmacology? And this question's been pursued in sleep medicine literature quite intensely these last few years. And what they found is that by phase locking acoustic stimuli to the peaks of slow waves, you can in fact recruit additional neurons to oscillate at that rhythm, boosting slow waves and getting downstream effects, notably increased memory consolidation, boosted immune function, and a decreased probability of being aroused by ambient noise. What's really critical here is that investigators have found that phase locking sound to the troughs, or not phase locking at all, does not affect slow wave power or those downstream effects. So the phase locking really is key. This has only been done during sleep, and no one's tried to do it during sedation or anesthesia yet, which was the purpose of our trial. So our hypothesis is that in-phase acoustic stimulation of slow EEG oscillations can increase arousal thresholds of humans that are sedated with dexmedetomidine. And this is a figure from our published manuscript, again, highlighting the fact that in-phase stimulation is what we're going for. So we're testing this in a trial called closed loop acoustic stimulation during sedation with dexmedetomidine. The intervention is acoustic stimulation during a target controlled infusion of dexmedetomidine to maintain steady state plasma concentrations. Our conditions, which are randomized across participants to account for an order effect, are stimulation either phase locked to peaks, which is in phase, to troughs, which is antiphase, or simply silence, which serves as our sham. Our primary outcome is EEG, which we're blinded to, and I'm not going to be talking about today. And we have secondary outcomes, which are pre-specified, specifically arousal thresholds and sleep architecture. So here's a snapshot of our experimental design. You can see a participant here who's being monitored with standard vital signs in addition to high density EEG with 64 channels. They're asked to perform a task, which is to squeeze a dynamometer as they breathe in and release as they breathe out. Over here, you can see our closed loop acoustic stimulation system and our dexmedetomidine target controlled infusion system right here. Bringing our attention to the right, this is our quantitative sensory tester, which consists of a thermode that we apply to the participant's non-dominant forearm. And the thermode increases by 1 degree Celsius every second until the participant moves. And we chose movement as our clinical outcome inspired by Ted Eager's original experiments defining MAC. So I'm going to be talking about the preliminary results of arousal thresholds in our first 8 participants. They were recruited between January and September 2021, all healthy ASA1 patients. So first thing that we looked at, of course, with our phase locking accuracy, these are phase histograms that are showing that over the course of 18,000 stimulations, our machine is in fact synchronizing in-phase stimuli to just before the peaks, which is 0 degrees of our slow waves, and our anti-phase stimuli just before the troughs of the slow waves, which appear at 180 degrees. So to briefly summarize the slide, the machine is doing what we wanted to do in terms of phase locking. Now the next question is it doing what we think it can do in terms of arousal thresholds? And so what we see is here is mean temperatures that were required to induce movement in our participants, as well as the 95% confidence intervals. And you can see during sham, it took about 48.8 degrees on average. antiphase 48.5 degrees, and in-phase 50.6 degrees. Now, to quantify the effect size of in-phase and antiphase stimulation compared to sham, we subtracted for each participant the arousal threshold during sham from antiphase and in-phase to create this graph here that you see. And so on average, antiphase stimulation actually decreased arousal thresholds by 0.4 degrees Celsius, but our confidence intervals comfortably cross zero. So really, we can't say confidently that there's any effect on arousal thresholds. Now, looking at in-phase stimulation, our average effect was to increase arousal thresholds by 1.8 degrees Celsius. And again, we can see our confidence intervals here range from 0.6 to 3. So then, of course, the question arises, is 1.8 degrees Celsius a clinically meaningful increase in arousal thresholds? And looking into the pain literature, looking at heat pain tolerance thresholds and heat pain detection thresholds, we see that clinically meaningful doses of opioids, so 30 micrograms of fentanyl, 100 micrograms of fentanyl, both epidural or 10 milligrams of IV morphine, are inducing increases in heat pain thresholds that are very equivalent to what we're reporting, so between 1 and 2.2 degrees Celsius. So what are our next steps? We're quite excited by the fact that we preliminarily seem to be able to increase the thresholds for arousal for participants non-pharmacologically. So our next steps are really going to be to dive into the EEG and look for mechanisms, and then to translate these findings into an ICU and OR setting, which is going to require quite a bit of redesign of the device itself, because as you saw from the original pictures, it is currently quite involved setup, and we'd like for it to be more streamlined for clinicians eventually. We'd like to also expand our stimulation modalities to include electrical, as well as ultrasonic and magnetic stimulation, so that we can leverage multiple different mechanisms to enhance slow oscillations and arousal thresholds as much as possible, allowing us to decrease the amount of medications that we need to maintain anesthetic states. With that, I'd like to open up the floor to questions and invite you to email me or connect with me on Twitter if you'd like to discuss more and get involved with future studies. Thank you.
Thank you. That was exciting. Question actually unrelated to anesthesia. Could the same technique be used in trying to suppress epileptogenic foci?
That's a good question. I don't know. I'm not aware of anything in the literature looking specifically at for epilepsy and seizures. So I guess I'm going to look now, but the answer that I have is I don't know.
It's just this dynamic feedback inhibition kind of stuff, right?
Yeah, exactly. No, it's interesting. I think that this technique has been pioneered by the sleep medicine scientists, but its potential for neuromodulation extends far beyond just sleep.
Yeah. Do you see any evidence of habituation to the auditory stimuli and the efficacy of the sound to either synchronize or increase delta power?
So that's going to be one of our big questions when we dive into the EEG, because we are seeing that in the sleep literature that at first you get a big boosting effect and then that wanes over time. And so what they're starting to do is sort of have windows of stim and silence and stim and silence to allow a reset of the system. We haven't looked at our EEG data yet. However, in case there is a habituation effect, we've cross-balanced the order in which we're arousing all our participants, either in phase, antiphase, and sham, to make sure that, for example, if it wanes and you're getting the most of effect when you're arousing them the first time, that won't confound our results.
Okay. And there's a question in the chat from Dr. Heifetz. Are there animal models for this phenomenon? And of course, it's super cool.
Yeah, it is a super cool phenomenon. I agree. And there are, actually, I know here at WashU, one of our investigators, Eric Lansness, is working with Aaron Norris to develop an animal model for closed loop acoustic stimulation. And so it's in the works. And I think that there is also some work that out of the University of Wisconsin in Madison, that's also looked into this to try to really tease apart the specific mechanisms that are leading to the enhancement of the slow waves. Right now, the best hypothesis that I've seen from the folks up in Wisconsin is that it's diffusely recruiting neurons across the cortex through the non-lemniscal arousal pathways, somewhat ironically, that's used to arouse the brain during sleep to sounds. But there is ongoing work definitely to make animal models.
Okay. From Dr. Orser, how effective are the acoustic stimulation been in other clinical conditions such as sleep disorders?
So very effective as far as I can tell, enough so that there is a huge now an push from industry to develop ambulatory devices so that people can bring those home. One such device is called the Dream device. And most of these right now are targeted towards maintenance of sleep states and having less arousal during sleep. I don't have the exact numbers, but I can follow up Dr. Orser with some of the literature that at least these companies are quoting for why they put in all the capital to actually miniaturize the devices for people to bring home. What has not been borne out is the sleep onset process. So they haven't been able to induce sleep in this way, in the same way that we're not inducing anesthetic states, but more so the maintenance and the enhancement of a state that is already occurring in the brain, those oscillations that are already occurring. But there have been some really exciting effect sizes for the immune system as well, and for the memory enhancement, like on the order of almost doubling the amount of explicit memory that you have of a task that you had to memorize something before a nap, and then you remember twice as many of those objects after the nap if you've had such a device on.
That's what I see on the chat so far. Any additional questions? No, if not, obviously, please continue monitoring the chat. And thank you so much, Dr. Gui.
Congratulations.
Thank you very much for the opportunity.
Afternoon. My name is Jacob Sunshine, and I'm happy to share this work with you about a closed-loop wearable naloxone injector system. I'm an associate professor at the University of Washington. My financial relationships are listed there. Relevant to this presentation is that this work was funded by the National Science Foundation. So the motivation for this work, so we're all aware that opioid overdose continues to be a challenging and massive public health concern. One of the things that makes it unique as far as cardiopulmonary emergencies is that it is reliably and readily reversible with the antidote naloxone and also supportive respiratory care. The issue is identifying someone who is in distress. Another unique aspect of this disease is that people who have opioid use disorder, if you ask them, they actually are open to using harm reduction technologies that would prevent them from experiencing an overdose or associated morbidity. And sort of with those things in mind, we sought to build and test an end-to-end system that's capable of identifying breathing patterns associated with opioid overdose, and then successfully administering the antidote naloxone near instantaneously. And to do this work, we developed the system in 2 locations. First, in a supervised injection facility, which I'll talk about in a moment, and then also testing of the end-to-end system, including administration of naloxone was done with healthy volunteers in the lab. So the system is sort of has 2 large components. The first being the respiratory monitoring element, which is composed of a dual accelerometer sensor package with a battery, a microcontroller that connects to a servo motor. The second part of this is the injector element. We used a commercially available FDA cleared medication agnostic injector platform developed by West Pharma, and sort of the combination of the system that can detect respiratory depression and then administer naloxone is seen here, along with a companion app that we developed that can give real-time indications of what people's respiratory rates are. That's it on the abdomen, and here it is in the process of injecting in the subcutaneous space with the deployed needle, and it remains in the retracted state before the injection happens. So where would we test this? Well, first we wanted to specifically test the respiration part of the system in a supervised injection facility in Vancouver, Canada. For those unfamiliar with these facilities, this is a place where people bring in often illicit drugs, and then they consume them under medical supervision. In our study, people provided verbal informed consent, and they were fitted with the respiratory element of our system, as well as a ground truth respiratory monitor with which we could compare how well our system was able to track respiration, and specifically respiration associated with opioid-induced respiratory depression. And so we would monitor people for 2 minutes prior to their injections and then 5 minutes post-injection. And so what you can see from the data here, first in the upper left, when we compare the accelerometer-based system to the respiratory plethysmograph that we had, the respiratory belt around their chest, they have quite high correlation, which you can see here. Another reflection of this data is through a Bland-Altman plot, which again, where you can see the mean difference between the respiratory rate measured was quite low as well. Not totally surprising, given that we sort of have two on-body sensing modalities measuring obviously the same person. Here down below, we have raw waveforms. Here you've got respiration, and then this is a labeled apnea event labeled by our study team in collaboration with the clinical team up there. And then here's an example of a raw waveform where you can see motion, which as you can see overpowers the breathing signal. Normally that might be a problem, but when you're looking for someone who's active and perhaps not completely slouched over and not breathing, that motion, while not perfect, still can be relevant as sort of a surrogate marker that someone's not overdosed. So this is where we did our testing to make sure that we could measure opioid impacted breathing, which can lead to bradypnea, respiratory rate less than 8, as well as smaller tidal volumes. So next, to test the end-to-end system, where we would combine measuring people having an apneic event with injecting naloxone and then measuring it went into the circulation, we used healthy volunteers for this. And so we would fit people with the respiratory belt right there, along with our system. We would have them breathe normally. Then we would ask them, reflected here, and then we would ask them to breathe at 8 breaths per minute to a metronome, and then followed by a breath hold to sort of simulate an apnea. And then after 15 seconds of that, the injection would take place. Here, we have labeled all the 20 participants that we did that. We took baseline blood levels, not surprisingly, no naloxone there, and then we measured 2 time points post-injection. As you can see for these first 2, we had poor coupling with the device on the abdomen, and we didn't get a successful injection. For the subsequent 18, we were able to measure naloxone levels in the blood, testing, having someone experience an apnea followed by the injection of naloxone. On the lower rows here, again, you can see that compared to that respiratory belt, the respiratory part of the system did pretty well in measuring respiratory rate accurately. So in summary, the thing I hope you take away from this is that people who are at risk for these overdose events, which is largely driven by fentanyl, are willing to use technologies to help keep themselves safe. We're shown that you can use an accelerometer-based system paired with already commercially available medication agnostic injector platform to successfully measure opioid-induced breathing, as well as in a simulated environment, inject naloxone when people pause their breathing for 15 seconds or greater. Limitations of this, obviously the testing environment, we won't like to test the end-to-end system with people who are engaging in the high-risk opioid use behaviors, and that's our next step. And then other next steps involve working with the manufacturer for a speedy injection of that naloxone payload to help resuscitate people faster. And with that, I'm all done. Thanks so much. And I hope you have any questions, please just let me know.
Thank you. I think we'll limit to one, maybe two questions at most for this. Very quick question. You mentioned the real world limitations to this, but how do you also scale it up? How do you make it so that it sort of crosses boundaries of socioeconomic differences or even the types of opioids, et cetera? How do you do that?
Yeah, so a really important part of this is sort of asking what people want, and because that's the way that you're going to get people to use a system like this. So there's been some great work out of Philadelphia who's been asking these questions, and these are people who have a socio-demographic profile that lots of associated homelessness, difficulty with mental health, and in that profile, which I think is driving a lot of these deaths related to fentanyl, there's expressed interest. I think a next step is asking people who may still be taking high doses of opioids, but may not engage in sort of these illicit, risky behaviors if they would be willing to use something like this. I think that's a little bit of a heavier ask, or for people who are just taking medications sort of as they're prescribed, even if they're on higher doses. So for some other work, we talk to people who are wanting to keep themselves safe while taking these medications, but we haven't asked them specifically about a device like this.
How sensitive is the location of the device? Does it have to be placed on an abdomen as opposed to an extremity?
Yeah, so for this particular use, we did two sensors. We tried one originally, and we just weren't getting a good reading. And so once we had two, we were able to add a different axis of motion and could pretty reliably do it. There's other ways that you can do it on the shoulder, and I've seen some groups doing that. I think they're using less accelerometer based and more using the pulse ox to deduce the waveform. To deduce the respiratory rate from that. So shoulder probably a little bit less invasive. That's another thing that the Philadelphia group found, was that having something that can preserve privacy and things like that is important, and shoulder is probably a little bit better than having something on the abdomen.
All right, well, I want to thank you for an exciting late-breaking project, and I'll ask you, like the other authors, to monitor the chat while we move on to our final late-breaking presentation.
Of course, great, thank you.
Hello, everyone. My name is Rudolph Davis. I am a CA3 resident representing Stanford's Department of Anesthesiology. Thank you for viewing my presentation, Hospital Level Variation in the Frequency of Postpartum Hemorrhage. Postpartum hemorrhage is the most common preventable cause of maternal mortality in the United States and abroad. It is an example of deficiencies in our healthcare system, as it is a very treatable condition, which can often lead to ICU admission, blood transfusion, and even death. There have been many maternal quality improvement initiatives and metrics which look at PPH prevention and treatment. However, there have not been many studies which examine how this care is delivered at the hospital level. In our study, we examined data from the California Maternal Quality Care Collaborative, where we linked data from birth certificates and maternal discharges from all live births in the state of California from the years 2011 through 2014. We identified 247 unique hospitals, which all had over 100 deliveries per year on average during this time period. Our primary outcome was to examine, based on ICD-9 codes, the rate of PPH at each individual hospital. To control for variance in our study, we used 4 models. Our initial model looks at social demographic factors related to the mother, so age and insurance status. Our second model controlled for variance among maternal medical conditions and pregnancy-related conditions. Our third model looked at peripartum conditions and the characteristics of the mother's labor. And our final model examined hospital teaching status and annual delivery volume by quartile. Next, for our statistical analysis, we calculated crude PPH rates for each individual hospital, and then used some models from our previous slide to calculate adjusted rates based on patient factors, hospital factors, and socio-geographic factors. This allows us to calculate a median odds ratio, which would explain that when picking another hospital at random, how likely it is for a woman to develop PPH based solely on hospital delivery. We also calculated an intra-class coefficient, which, when looked at in this context, will explain how similar patients are and how much of the variance is explained by the patient population or other demographic factors. Secondary analyses in our study look at the hospital variation in transfusion, correlation between each hospital's adjusted and unadjusted rate, as well as ICD-9 coding intensity, examining how hospital coding may play a role in how PPH is reported. As we move on, we'll begin to examine our results. For our data set, we began with nearly 2 million deliveries based on birth certificate data. After excluding multiple deliveries, stillbirths, gestational age outside of our range, hospitals with very few deliveries, and also missing data, we were left with 1.9 million unique women with deliveries. Here's a scatter plot showing all of our hospitals ranked by PPH rate. Our median unadjusted PPH rate is about 3.5%, with the lowest and the highest in that range being 0.5% and 12% PPH rate based on all live births at each individual hospital. In our fully adjusted model, our data looks very similar. After adjusting, our lowest PPH rate was 0.6% and our highest 11.5%. Our median, however, is unchanged. Based on our data, that when a woman goes from a low PPH hospital to another hospital at random, she is twice as likely to experience PPH based on our median odds ratio of 2.1 in our null model and in our fully adjusted model of 2.0. Our intra-class coefficient shows that there is very little similarities between each patient at these hospitals, with even less variance when the models are fully adjusted. As we move on, we'll examine our secondary analyses. Here, we look at our unadjusted transfusion rate. Transfusion is a very rare event when related to PPH. As such, we were unable to calculate adjusted rates, and our model does not appear to be convergent. Unadjusted transfusion rates at our lowest incidence hospitals was about 0.1 or a tenth of a percent. Our median was 1.1%, with our highest outlier at 6.1%. Next, we look at correlation between crude and adjusted PPH rates. As you can see from our graph, there's a strong correlation between the adjusted PPH rate and the crude PPH rate, meaning that even when adjusted for with all the factors in our model, hospitals that have low crude PPH rates also will have low adjusted PPH rates and vice versa. Next, we looked at coding intensity, as we were curious if hospitals that reported fewer patients with PPH also reported fewer ICD-9 codes on discharge data. As you can see here, there are slight variations between our first quartile or lowest PPH hospitals and our highest quartile or quartile 4 PPH hospitals, with on average 6 ICD-9 codes in the low PPH group versus 8 ICD-9 codes per patient in the high PPH group. In summation, our study found that PPH rates vary significantly between California hospitals, with as much as a 16-fold difference between low prevalence and high prevalence hospitals. Even after adjusting for many patient variables and select hospital factors, we were not able to explain most of our variation. Further work is needed to examine specific hospital practices that explain some of this variation, as well as the impact of quality improvement initiatives and how they can go about reducing the variation between high prevalence and low prevalence PPH hospitals. This concludes our presentation, and here are a few references I used in putting it together. Thank you for taking the time to view my presentation. I will be available for the question and answer period to follow. Thanks again. Bye-bye.
Thank you for the presentation there. One question already in the chat here. I can't read the full name here, Dr. Olubukola. Did you include parity, race, ethnicity, and maternal BMI in your model?
So we did include, well, we excluded parity. So for people that have multiple deliveries, so a twin, triplet gestation, it's just one delivery. So we include that as far as the model goes. We did not include race or maternal BMI as far as maternal factors. We did include other associated maternal diseases, such as like gestational diabetes, gestational hypertension, but we did include BMI specifically.
Okay. I think I see a comment from Dr. Williams saying, great but very disturbing talk, young man.
Yeah, it's one of those things where I know we all, as being in anesthesia and healthcare, you often get to see what healthcare actually looks like when it's being delivered. But if you're a person that's not in healthcare, you really don't know if it's a good hospital or a bad hospital based on any metric or ranking. So,
yeah.
Are there lists that are published for, as we think about trying to improve access to this information, are there databases in which an average healthcare consumer could look on the web and find rates of postpartum hemorrhage?
So I know there's like a lot of those lists, like the Leapfrog, Vizient, they have those like consumer product lists where a lot of it's based on like, I guess, patient satisfaction and their interaction with the healthcare system. But as far as like our data came from the California Maternal Quality Care Collaborative, where they actually looked at all these rates on discharge data, not actually looking at how patients felt with the experience, but looking at actually how they did long term. So as far as like actual where a consumer or just a lay person could go and look these things up, I'm not sure if those things kind of exist.
Okay, there are no additional questions. Oh, hold on, there's one more from Dr. Orser. Were there important differences between hospital outcomes stable over time? Sorry, were these? Yeah.
So for each individual year, it was about 3.3 to 3.5% rate each individual year for the sample that we looked at. Now, this is data from about 10 years ago, so 2011 and 2014. I see another message in the chat about the TXA use. And actually, in the state of California, we came out with, well, at least the Maternal Care Collaborative came out with a bundle for PPH and trying to standardize care in the year 2015. So it would be interesting to look up to see if these rates have started to go down after they've had to adopt this bundle. But at least for the study period of those 4 individual years, it was about stable, about 3% rate statewide.
Okay. And then the final question was tranexamic acid examined, use of tranexamic acid.
But we didn't actually look at any other care delivered at each individual hospital. As you can imagine, it's kind of difficult to look at individual hospitals' practices from database level.
Okay. Thank you so much, Dr. Davis. Max?
Yeah, it looks like there are a couple more questions which we'll ask you to reply to in the chat. And then the moment of anticipation that I think our audience may be waiting for, in addition to hearing the last phenomenal talk, will be the Kosaka Abstract Awards, and Dr. Prakash will be presenting those now.
Thank you, Max. First of all, I want to sort of say the future of academic anesthesia is bright. I'm really impressed with the quality and the depth of the talks that were presented today. I have to say, you know, it's not easy to do research in the current environment, certainly post-pandemic and all that good stuff. And so in that sense, I'm impressed by the research that's been done across the trainee and the faculty spectrum. So congratulations to everybody who participated today. It's my pleasure to announce the winners of the Kosaka Best Abstract Awards. As Dr. Kels mentioned early on, there's Basic Science, Clinical Research, and Scholars. So the Basic Science Research Award goes to Dr. Andrew McKinstry-Wu from the University of Pennsylvania for his presentation on glutamatergic and adrenergic neurons mediating alpha-2 agonist-induced sedation and hypnosis in mouse models. The Clinical Research Award goes to Ms. Wong from Duke University School of Medicine for cognitive and cerebral fluid Alzheimer's disease biomarker changes over time in older surgical patients and matched non-surgical controls. And finally, the Scholars Award goes to Ms. Tsai from UC Davis School of Medicine for integrated single cell and plasma proteomic modeling to predict surgical site complications, a prospective cohort study. So congratulations to the 3 winners. And look forward to seeing more of you and all the other participants as well in hopefully future in-person meetings and other avenues where academic anesthesia prospers. Max?
I'd just like to bring all of our presenters back online and emphasize that it was stiff competition, not only for the 3 awards that we could give out, but for everyone getting the opportunity to present here. So thank you all for your hard work and for helping to make the IARS meeting a phenomenal success. Congratulations.
Congratulations to everybody. Thank you.